Thank you. Good morning. Thank you for taking time out of your busy schedule to be here with me today on a topic very important to me, rural health care. A little bit of background on myself. As Claudine mentioned, I have over 28 years of rural healthcare experience. The first 23 years of that was actually working in a couple critical access hospitals on the provider side, working with rural health clinics, and it allowed me to get a great understanding and appreciation for what it takes to operate a hospital, regardless of the size, and more importantly, how fragile rural hospitals are and the importance of the community support. For the last 5 years, I've worked for the Rybar Group supporting rural healthcare providers across the country, ensuring that they receive the reimbursement they are entitled to and are capitalizing on the different opportunities available to them. Over the past 5 years, I've also had the opportunity to assist several rural hospitals as part of their finance team, including in an advisory role as needed, oversight assistance on a regular basis, and actually to be a full remote department of the finance of the hospital with daily hospital interactions. So I have bring a wide variety of actual hands-on experience working in small rural facilities. Looking at the disclaimer we have, again, as everyone that's working in healthcare knows, information changes more often than we sometimes realize it does. So information is all correct and current as of today. These are just our other disclaimers. And on with all of this, as was mentioned earlier, the handouts will be sent out at a later date. So let's look at our agenda objectives for today. With our participants here today, we have a wide variety of representation. We have individuals working for critical access hospitals, for rural facilities, for systems, and also supporting partners. So I hope the presentation helps get a wide variety of information to you as well. We also have a huge range of experience. We have some individuals new to healthcare. Some of this might seem overwhelming, but welcome. We appreciate having you in the healthcare field supporting rural hospitals, and some to very seasoned professionals. So the intent today is to discuss the different pain points for rural health, identify the different rural healthcare provider types, discuss the various reimbursement models and the related revenue opportunities, and just to get a general understanding on the programs and reimbursement opportunities that are available. The end goal, again, is to share some background on rural healthcare providers, how they are the same, how they are different than urban, and again, looking at what is available to you from a reimbursement side. Although the current pandemic has consumed a large part of our lives, both personally and professionally, over the last 2.5 years, my presentation will focus more on what we consider normal times, even though the new normal might be different than the pre-pandemic normal, but there will be a few instances that I will divert. Resources are available throughout the presentation, and especially at the end. There were a few questions asked prior to the presentation today, and then I'm working on those. More specifically, I'll reach out directly to those individuals with a few other follow-up questions to make sure I'm answering those appropriately, but please ask questions as we go throughout. So to get started, let's answer the question. Is rural health really different? And yes, it is. That's why we're all here today. So next, what is rural health? And what's interesting about this is it really depends. It depends on who's determined the classification, what funding program is there, where you're located at, when the data was updated, reviewed, and how the data is interpreted. There's not one definition for rural. I appreciate all you being here today, and I'm really hoping at the end of this, you'll see what different programs are available to you, depending on what program you're looking at and where you're located within the US. So the different rural classifications look at different opportunities, whether it's funding, recruitment, retention, or actually reimbursement. And rural areas basically are defined as anything that is not urban. So the census looks at everything that's urban, and then if it's not an urban area, it's determined to be rural. So this is an excellent, phenomenal website, Am I Rural? And again, the link will be sent out later. But with going in here, you put your exact location of anything that you're doing, or any location of your current hospital, current clinics, future purchase properties, if you want to expand clinics. And what it does, it looks at your current scenario and will look to see what you're eligible for. It'll go in and say if you're eligible for the rural health clinic program, if you're eligible for certain grants, what other rural definitions there are, and also the different shortage areas. And I have an example here of just one location. And what it is, it's an excellent snapshot. It'll print off in 4 different pages. The first page will give you, and remember, everything is address specific, but this is a great way to look to see what you're eligible for. Across the street might have a different end result than where you're located at. 1 mile away is different, across town is different. There's 70,000 different census tracts it looks at. And it'll do is check with, it'll allow to tell you whether you're eligible for certain programs or not. The second page has a nice rural, and it shows red or green, if you're eligible for the program or if you're not eligible for the program. And again, if it's not in an urbanized area, it's considered rural. So take in mind when you're looking at that, that's how it's going to determine those. But this will help you determine what rural health clinic programs if you're eligible for, if you're eligible for different grants through the Federal Office of Rural Policy. Page 3 looks at a lot of other different definitions. And this information is good to know for different funding mechanisms that you're available for. But keep in mind, for anybody that does any grant writing or other sources of funding out there, it's also a nice way to look at some of your key demographics for your area. So you can help tell the story of what you're doing in your area and where your population trend looks like. So this also looks at other rural information, again, that's based on census data. Again, look for grant opportunities. It'll help your RUCA, helps your RUCA score here is a good thing that HRSA looks at as well. And again, HRSA, each different area of the government has different definitions of rural. So keep in mind that that's also the case as well for that. And then page 4 actually gets into the different other shortage areas. So it'll show whether you're in a HIPSA area, whether it's primary care, dental, or mental, and then also the medically underserved areas. So it's a nice place to look at to see some of those key programs that you're available. There are hyperlinks built within the report as well, which is helpful as well. So let's just look again real quick. Within the RHI Hub website, there's also other information. I chose Michigan because that's home base for me here, but it's also an excellent resource that looks at data available for every state. So when you go into the RHI Hub website, you can actually click on your state and it'll give you very specific information there about funding, local contacts, recruitment opportunities that's available. This was updated as of July, and you can see it's through the HRSA website. And if you look at it, the beige pockets that you see on your specific state, we have 14 different states here today, so I wasn't able to pull all states. But when you pull up your specific state, those beige pockets are considered the urban areas. Everything that's not a beige pocket is considered rural for a type of program. Again, you just have to look to see which type of program it is for you specifically. So let's look and see, how are rural and urban the same? So people make a choice to live, whether it's family and friends, work, education, but they all have the same basic needs. People still need healthcare services for preventative, for injury, for illness, and for ongoing care needs. One of the health disparities in the US today is the degree of geographic location of where individual resides. For me, I was born and raised on a farm in rural Michigan. I married a crop farmer, so my choice was more obvious to raise our girls in a rural area close to our families. For the majority of Americans, the rural setting might not support their choice, whether for lifestyle or culture, but regardless of a person's zip code or view from the front window, we all need access to healthcare services. So looking at other differences between rural and urban as well. And again, this would be another key area to look at and use as support for any grants or any other storytelling that you need to do to look at other funding opportunities. But if you look at this biggest area up here, 19% of the population lives in rural, 80% lives in urban. But the urban area, those beige pockets that show up on all those states, actually only makes up 3% of the entire landmass of the country. So 80% of the individuals live in 3% of the country. This probably doesn't surprise the majority of individuals that live in rural America, but 19% of Americans live in the 97% of the country that's considered rural. So again, it's looking to see in your specific area what opportunities are available for you. The majority of rural Americans lack access to stable, adequate bandwidth, which is another area that I know is out there for funding opportunities. And the other key demographics is in the rural areas, the poverty is usually higher. There's most new jobs are not in rural areas. Disabilities are more common in rural areas, and rural areas can be more entrepreneurial though. So that's another positive side. But again, it's very important and challenging job and responsibility to provide access to healthcare to those rural Americans. So let's look at a few other areas to how rural is different than urban. Usually there's fewer options in the rural area, but that doesn't mean there's lower quality. Same as there's 1 to 2 gas stations in a rural town instead of 1 at most stoplights in the urban city. Fewer clinical services available sometimes does is because of lower volumes that are there. Transportation in the rural area is another sometimes hindrance. Usually the travel distances are longer, and not necessarily in the time it takes, but in the miles is an issue in rural America. There's no public transportation in most rural areas, no Uber drivers. Plus, there's more miles that have to be taken. And for those of us that live in the northern half of the US, you can also look at the inclement weather and the changing weather, which helps, which usually can equate to more time taking to travel to doctor's offices or to the facilities or to hospitals or just to get to general services. The other area is recruitment of, it used to be just providers. It used to be just an issue to recruit professional individuals. But as everyone's seeing across the country, recruitment has become an issue with providers, with clinicals, and actually with physicians, with clinicals, including lab, x-ray, pharmacy, therapies, and then also the non-clinical staff, whether it's in the management side, not just the C-suite, but also department managers. And then even into the clerical side, getting into the registration desk and getting into the controllers, the patient account managers, the business off managers. It's hard to get individuals to do those frontline jobs sometimes. The community support is an important part for the success of rural facilities. Usually the hospitals in the rural areas are the largest employer in the area, which makes a significant contribution to the local economy. But the same is in return. If there's factories in those small towns that close or other businesses in those small towns that close, it can really hurt a rural provider, both financially. Community support is also huge for important and success for rural facilities. If you look at those that are governmental, looking at millages for fundraising efforts, for utilizing the services, and for the retention of staff. So it's very important to keep your community definitely involved with everything going on with your facility to keep that volume there. Usually, you also provide services across the continuum of care, from the primary care to long-term care. In the urban areas, there's usually different providers that will do home health, that will do long-term care, that will get into all those different subspecialties. A lot of times in the rural communities, the hospital is the one that has to provide all those other services. They're expected to bring the home health, the health fairs, the long-term care, the ambulance that again in larger facilities they already have. And then, of course, you have the limited staff with the same reporting responsibilities as larger facilities. And sometimes it gives you time constraints with fewer staff. Plus, the staff has multiple jobs and responsibilities because they're more hands on. So, for those of you that are new working in rural healthcare, congratulations. It's an exciting place to be. You will learn more than you've ever imagined. Look at it as a huge learning opportunity. Within the smaller organizations, you can really see everything that happens within the organization, and it tends to be not as siloed as sometimes it is in a larger organization. And it's a really exciting place to be. So congratulations on that. So next, let's look at the rural strategy. So rural definitely is different than urban. In 2018, CMS actually produced their first ever rural healthcare strategy. So it was exciting for me to see that they're actually focusing on rural healthcare in the US as a part of the CMS initiative. And the importance of that is the development of a strategic plan to improve healthcare in rural America, to reduce provider burden, and to make healthcare in rural America accessible, affordable, and accountable. And some of this really started to develop and take off. And then, of course, when the pandemic hit, it kind of slowed down a little bit. But the exciting part is, even within the pandemic funds or the COVID relief funds, there were still some carve outs from rural providers. So it's definitely a very important aspect of the federal funding of the governmental side. The other thing on the rural strategy side is looking at the payers. Sometimes it's really hard because you need a higher reimbursement because of the smaller volumes, but it's also difficult to exclude when you need the patients. Don't forget about the geographic coverage that you cover. So you might be in a rural area, but you have a huge geographic area that you cover. So make sure you keep that in mind when you're negotiating with your payers. And then keep your lines of communication open with your large employers in the area. Again, as I just mentioned, when factories or other businesses in your town are struggling or they have to close, that's a huge impact. But I've also seen where, as of January 1st, a factory move or an organization or company within the service area will switch to a new insurance plan or sometime throughout the year. If you're not aware of that from the hospital side or from the provider side, and you're not already in contract with them, that can be a hindrance for you as well. You don't want to find out after you've already billed claims or after they've already been seeing patients that you really need to rush out and get a contract because you're behind it already by that point in time. So keep those lines of communication open with your employers. Remember though, even though you're in the rural area, you still can't be all things to all patients. It's too hard with the low volume side of it. But the one thing with rural providers is they can be the best at what services they're providing. Usually, rural providers have the highest patient satisfaction across the country, and they usually have a higher retention of staff and providers. Although the recent last couple of years have hurt that, it still does usually have a higher retention for the rural providers. So keep that in aware of that as well. So why is it important to be aware of these differences? For three reasons. You want to know what reimbursement opportunities are available to you, how you should be reimbursed, and then at the end of the day, how are you actually being reimbursed? So you want to know how you should be reimbursed, but it's also important to follow up to make sure you're actually being reimbursed in the way that you are expected and needed to be reimbursed. And remember, your facility and your community are unique to you. So as we talk through different topics today, there might be a few things that you can't do in your area. There might be a few things that maybe you could look at doing, but just keep in mind that each facility and community is unique. And though all similarities may exist, it's not a one size fits all answer. So I think we're ready for our first. We have two polling questions for today, and I think we're ready to launch the first one, please. Claudine, are you able to launch that first polling question, please?
It should be showing right now, Karen.
Okay, thank you. Because I can't see it on my side, so thank you.
Uh, yeah. If you look in your chat, Karen, you'll see it
I
there.
got now. All right, so it looks like I always struggle with these because to me, I didn't put a not at all the above. Because sometimes I actually, throughout the facility, I'm sure a lot of individuals are looking at all the above. But I also try to recognize the fact that not everybody on the call today actually works for a healthcare facility as well. So I appreciate that. But staffing definitely is a huge area in recruitment and retention, up to that. That looks like the majority of it right there. So that's, and again, this is an area where it's urban or rural sometimes have the same issues, but what we're going to get to, and again, is looking at the rural side of it. Thanks, Claudine. All right, so when we look at the rural healthcare pain points, there's still continued vulnerability of rural health. So when we're looking at patient volumes, there's still inefficiency issues without adequate volumes. The aging of the baby boomers, the fee versus value or volume. The second area, again, looking at the staffing costs, and actually I lumped into here the recruitment and retention of staff. Looking to see if the staffing of scarce resources is a challenge. But that's just an area that I'll show you a few resources you can possibly look at later for opportunities there. Other organizational costs, again, looking at that lower margin creates capital funding constraints as well. Also looking on the rural healthcare providers usually tend to be more efficient than their urban counterparts just because of their lower volumes and their revenues. So sometimes there's little left to cut for those rural efficient providers, which makes these challenging times even harder. And also sometimes cutting too much can cause unforeseen challenges and issues as well. If you have to cut too many expenses, it makes it harder to provide some of those services. Plus, there's a risk with the impact of volumes and then the safety and quality side of that as well. The fourth area is the cash flow. And again, I'm sure everyone's aware there's been a huge shift of payments to the patient responsibility. There's higher bad debts. The patient is now the third largest payer due to high deductible plans. And again, this is probably nothing anybody new in here hasn't, or the newer individuals should be aware of this, but for those that are seasoned professionals are aware of this. But again, the payer rate increases is not keeping costs pace with the cost. Sometimes the volumes are lower, so it's harder to negotiate again with those payers. And you need to really focus on that geographic coverage area rather than the number of patients and see what you can do that way as well. And then the last area is just like a miscellaneous category. What I looked at there was the hospitals are continuing to have to be strategic in growth and market share. And this is really hard because sometimes you're hesitant because you can't afford to swing and miss. And also it's hard to know where to sometimes to expand services and where to contract for them. It's hard to be competitive sometimes. And again, we can't be all things to all people and the real providers. As smaller providers are also sometimes in larger systems, sometimes they don't receive the same attention. And not only just that, but they're different. They have different funding mechanisms, and sometimes they have to look at everything differently because of the reimbursement opportunities that are available to them. And then there's also not one universal definition of rural. So it's hard to know which different programs have that are the different definitions of what you're eligible for. So why is it harder to recruit providers? And it used to always, my slide used to say providers, but I actually added in other staff because there is a consistent issue with recruiting other individuals as well. And so it's looking at one area to look at that is there is loan repayment opportunities that are available for your specific location based on who you can recruit and retain to that area. There's also not as many providers there, so there's sometimes a larger on-call commitment. And then sometimes seeing those patients outside into the offices sometimes can be an issue too, but it's really important to get those providers and staff involved in your community and get that spousal buy-in. If they have children, getting them in school settings, getting them into other religious or cultural settings as well is important. Sometimes it's also hard for the rural providers to pay as much as the urbans areas do, just due to lower patient volumes and therefore revenue. But the other area to look at this with some of your providers or other staff that you're recruiting is the lower patient volume. Sometimes it is more on the specialist side, but the lower the pay, even though you get slightly paid lower in the rural area, sometimes you can still be the highest paid in the community as a provider, and you can still live significantly cheaper. So your cost of living would be less, but yet you can still be in the top percent of your community as well. So the National Health Service Corps is one area that you can look at to help with that. They actually have the National Health Service Corps and the Nurse Corps program are actually working together to help rural providers recruit and retain individuals. So you, for eligible primary care providers, are actually can be the whole list on the screen there. They can be the physicians, the nurse practitioners, the physician assistants, dental, mental health, registered nurse, pharmacist, substance abuse. All of those are key areas within the National Health Service Corps and HRSA. You do have to be an applicable site. So for those of you that already have become a new site, congratulations. That's, I know it's not a small feat, but at the same time, once you're in there and as approved in a site, you have huge benefits that you can do. There's the loan repayment, scholarships, different preferences. And again, the website is on there for you to look at later as well. So let's look into the different rural healthcare payment programs. So there's 5 different programs that are out there for rural healthcare providers at this point in time. So we're going to look at the background, the requirements, and the characteristics. And again, keep in mind though, as you're looking at each of these, I'm sure everybody on here is aware of each of these 5, one way or the other, but or you already are assigned, or you already are a provider for one of these 3, approved as a provider for one of these 3. But remember that what that 20% or 1 in 5 Americans live in rural America. So the intent behind all of these is to reduce financial vulnerability and improve access to health care. So that's what these programs' intents are. Remember, those rural hospitals have the same regulations and requirements as the urban facilities, but sometimes they lack volume to be cost efficient or break even on the critical services that they offer. The other thing that we're going to talk about in a little bit too is in regards to the different funding that's available for these as well, and the different cash flow challenges that have been there. So even though if you've not looked at one of these in the recent past, or if you are one of these, before you ever jump into something else or think this is what you want to do based on the presentation or anything else that you read, you really want to make sure that you model the impact of that. So you want to make sure that you're actually going to benefit it, first of all, financially, but it's also a good fit for your community. This is a quick snapshot of where the critical access hospitals are located across the United States. There's 1,360 of them as of April, or actually as of July. The fun part to note on here, there's actually 5 states without critical access hospitals, and they're in this region right here, obviously, because they're very urbanized. So there's actually those 5 states there do not have Connecticut, Delaware, Maryland, New Jersey, and Rhode Island do not have a single critical access hospital. And even though I'm going to be spending quite a bit of time talking about critical access hospitals and rural health clinics because they're cost-based reimbursed, sometimes that's where the biggest opportunities exist. If you also are working for another rural healthcare provider or any healthcare provider from a hospital side, keep in mind a lot of things I'm going to be discussing are still important for you to keep track of and to look into, because even though it might not directly impact your Medicare cost report reimbursement or other direct voucher reimbursement, it still can affect you down the line when you get into your dish payments or other Medicaid funding or other opportunities as well. So even if I get into and talk about critical access hospitals a lot, keep in mind that cost report is equally important for you as well. So when we're looking at the critical access hospital program, just a really quick oversight, 25 or fewer beds. It was established in 1997 as part of the Balanced Budget Act. in response to the almost 400 closures that occurred in less than 10 years. And again, the purpose of the program is to keep essential services in the rural communities through cross-based Medicare reimbursement. And as of right now, there's 1,360 of them across the US. So when we look at the different services that critical access hospitals can provide, the critical access hospitals across the country are the same, meaning they have the same basic requirements for becoming one. They're located in a rural location. They have recruitment and retention issues. They have providers. They have everything else that a larger facility does. The difference is CASA can be significantly different, meaning that sometimes the location, some can be significantly more remote than others. They have different services that they offer. They have different relationships. Sometimes that recruitment and retention can actually hurt them if they have longevity of they have providers that have been there for a long period of time that all of a sudden leave. That can have a major change in that revenue and volume when providers leave or retire. The other thing is with the services here, this is like a kind of a laundry list. Basically, critical access hospitals can provide any services as long as it meets the requirements of them becoming a CA, as long as the average length of stay for your inpatients, not including swim beds, is under 96 hours, and more importantly, that they also meet the community's need. That's the important part is to keep, and it's important to provide those essential services to their community. So for some of the providers or for some of the staff, like occupational and speech therapies or other areas, they can be employed individuals performing those, or a lot of times they end up being contracted because they can't afford a full-time physician or a provider or a mid-level. Looking at the critical access hospital, there kind of is 8 different special Medicare rules that we're talking about here. And again, a few of these will also carry over to other rural providers as well. We're going to spend a little more time with the critical access hospitals and the other ones just because there's so many of them across the country. But the cost-based reimbursed at 101%. So a lot of individuals look at that and say, so how come critical access hospitals are struggling? They're getting a 1% over cost. But keep in mind that's only looking at the allowable costs. It doesn't include marketing. It excludes physician recruitment costs. A lot of things that are excluded from the cost report can be excluded from the cost report if they're not considered allowable costs. And then critical access hospitals usually provide other community service needs, again, getting into those health fairs, long-term care and home health that are not cost-based reimbursed. And then as of July 1st, we also went back to the 2% sequestration. So at the end of the day, the actual best reimbursement that a critical access hospital could receive is 98.98%, because again, not all costs are allowable. So that would take it even lower than that. So when we're looking at critical access hospitals for Medicare, let's say 40% of their business is Medicare, so that's 98.98%. Medicaid is usually best case scenario would be cost at 20%. So that leaves 60% of the business in most critical access hospitals at less than cost. So that leaves your other 40% of your business that you need to profit from. And keep in mind that would include your self-pays and your bad debts and other issues like that. And there's more and more moving over to Medicare contracted HMOs. And sometimes those rates are even lower as well. So you really need to look at your rates for your payers as well to look at that and focus on other sources of revenue opportunities as well. Number 2 is looking at swing bed services. So again, what this is a post-acute care bed. And the really important part about this is usually there's a high Medicare utilization, so it helps pull cost overhead that way. A patient in a critical access hospital with a 3-day length of stay, or this is a key part, they can also be transferred back from another hospital to utilize the swing bed services. This is an area that we've seen a lot of critical access hospitals do well with during the pandemic, because especially if they're part of a system, the system would keep the critical access hospital with non-COVID patients and send those swing bed patients back to the hospital to help recuperate as well. So that's an important part about that. And it keeps those patients back in the community or brings them back to the community, which is really important in rural areas. There is separate certification for that and approval, and it gives you a separate provider number as well. And the swing bed services are part of your 25 beds. The third area on here is the 340B benefits, which is one area that has been highly contested over the last several years, has seen significant proposed cuts going through. But for critical access hospitals, you're all eligible for 340B pharmacy benefits, which includes contract pharmacy as well, which helps with the significant revenue opportunity there. It's another non-patient care related revenue that you can benefit from as well in your community. Number 4, you're excluded from some of the provider-based rule changes. Number 5, there's full cost reimbursement for rural healthcare services. Now, there is some changes that happened to there a year and a half ago that we'll talk about in a different slide. Number six, you have professional provider opportunities. So think of this as you have option two billing you can do, which is 115% of the Medicare fee schedule. You can also possibly get, depending on where you're located, a HIPS add-on as well of 10%. On your A82 for your cost report, you're exempted from the RCE limits. You have your physician standby time that you can be reimbursed for. You have CRNA costs that you can sometimes reimburse for. Number seven, the more flexible staffing requirements allows you to use non-physician providers in the clinics, in the ERs, and in other areas throughout the organization. And number eight, the capital funding. You're more likely to be eligible for USDA loans, flex grant programs, HRSA grants, and other funding opportunities that are out there as well. So again, when we're looking at the Medicare cost report, and again, even though it says critical access hospitals, think about this with any rural provider that you are either working in or working for. So it's really important to look at the accuracy of the charges, the costs, and the stats. Your current year reimbursement is and your future year interim rate payments depend on it. And keep in mind with cost-based reimbursement, you don't want to leave money on the table. Think of it like a tax return. Even if you're not directly involved with filing these cost reports, and I know a lot of individuals on the call today are not directly involved with actually filing the cost report or preparing it, it's still important to understand the key components. Because if you work within a critical access hospital or any other rural provider, you still have an impact and you can have an impact on what that cost report comes out at. And we'll explain that more in a little bit. But it's really important to look at the communication on that first one for the accuracy. Again, everything impacts the cost report. If you think about the charges, how was your charge master set up? Think about the cost side of it. Think about how AP works, how HR and payroll works. Look at your ER physicians, looking at your stat allocations, and then really looking at your departmental cost to charge ratio swings. You really want to look to see, you want to monitor if it's a high Medicare service line, think of inpatient, think of your ORs if you do in orthopedic surgeries. Those will impact your reimbursement the highest. If it's a low Medicare service line, are you being reimbursed more than your cost? And it's something else to look at that way. Limit your non-allowable cost as well. Be creative, non-provider based activities, advertising, bad debts. See what you can do to keep these costs in here as much as possible, appropriately, of course. Then next, look at your charges. So the second one on here, review your charges. Patients pay 20% coinsurance on outpatient bill charges. So make sure your charges are not so high that the majority or all of the outpatient services are paid by the patient. And I'll give you an example today in the next slide. And then very importantly, on an interim cost report or anything else you do to make changes, make sure you model the reimbursement. Make sure that you look to see, it should not be your only part of your decision-making process, but make sure that it's included in part of the process. When you're thinking about your budget, contracting with other payers, purchasing equipment, leasing, staffing, physician contracts, if you're going to start a service or if you're going to end a service, those are really important to see what the impact is going to be. You just don't want any surprises later. Charges and volumes change, costs change, payer mix changes. So at the end of the day, all of that is going to change how you're reimbursed. Throughout the year and at the end of the year and after the year. And then it'll impact your future year interim payments until you can have an adjustment made for that as well. With your other reimbursement opportunities here as well, look at your Medicare managed care contracts, make sure you're getting at least cost-based reimbursed on it, and then look at your bad debts. And this is an area that has been scrutinized more in the last couple of years. Make sure it's that it was wrote off and sent to the collection agency and then returned as worthless before you put them on the cost report. The auditors are really starting to look at this a lot more, making sure you have copies of bills, that you have ceased collection efforts, and that you have an internal auditable collection policy and have the specifics in the collection agency's agreements on their responsibilities to assist you with meeting your policies. And then the other area with just the Medicare cost reports and with everything in general, make sure you get copies of all your work papers from your cost report preparer and keep them for at least 5 years. We can go in and you can always go in and retroactively request an amend or reopen a cost report for quite a few years after the fact. Ideally, you want to file your cost report and get it done and never make any changes to it. But sometimes there is opportunities for retroactive reimbursement. And if you think about everything that's happened in healthcare or across the whole country, and no matter what industry you is, there's staffing changes. And sometimes there's ownership changes. And if those work papers or that support at how the cost report was filed isn't available, it makes it really harder to look at down the line. So next, we're going to look at, this is like a really quick example of that outpatient charge copay that I mentioned before. So if we look at outpatient charges, and again, exact same services, depending on how the charge was established, 10 million, 8 million, or 6 million, exact same costs at 5 million. Then you look at what that cost to charge ratio would look like in 20% of charges. So at the end of the day, a $10 million is going to be $2 million going to the patient. Here at 6 million for the exact same services would only be 1.2 million going to the patient. So keep in mind, this isn't something you want to take by itself. You really want to look at what the impact would be with your commercial payers as well. It's not just a Medicare impact, but keep in mind your bad debt savings. You're only going to, if it ends up going to bad debt, you're only going to get 65 cents on the dollar. Plus, it's going to take you a long time to get that reimbursement between 3 million, between 1.2 or 2 million and 1.2 million. That under $800,000, it's going to take you longer to claim it or receive it. I mean, Medicare cash you can receive within 15 days of a clean claim. Your bad debts are going to take you 3 years if it ends up getting there, if not longer, to put on a Medicare cost report. So it's just an idea to look at is from a PR side that you're looking at your cost, you could keep your charges down, but again, you want to make sure that you look at the commercial impact of it, and then also make sure you communicate to Medicare. So if you ever do anything with charges where you're going to drop your charges, make sure you communicate that with Medicare and actually do an interim cost report to get your interim rate going up and increased so that you're not hitting the short run with cash flow issues. So really quickly, rural health clinics. This is the second provider type out there. It's the fastest growing rural healthcare provider type in the country right now. There's been a 25% increase in rural health clinics over the last 5 years. There's now over 5,000 rural health clinics across the country. Quick overview, you must be physically located in a HRSA designated area, kind of like that slide I showed you earlier. You have to employ at least one non-physician provider. One has to be employed. You can have other ones that are contracted, but one has to be employed. And then there's two different types out there. There's a freestanding, which is 43% of the rural health clinics are freestanding. There is reimbursement limits. There's per visit caps on there. And there's also provider productivity floor issues as well that can exist. And then there's the provider based, which is the more popular one or more that is affiliated with hospitals. There's 57% of the rural health clinics in the country are provider based. They do have some new rules that took place into fiscal year or into 2021 that we'll talk about in a minute. But those are the different types of rural health care provider types that are out there. Looking at Medicare alone, there was a significant change here done in 2021. So this is a very simple slide to look at it. There's all types of big slides out there that'll actually show the whole dynamic of what the different funding looks like. But there's a huge change in the range of provider-based clinics. So as of 1/1/2022, a provider-based rural health clinic with less than 50 beds enrolled before 1/1 has a clinic specific AIR with a cap on it. You still have to do your cost report, but you cannot go above this cap. For those independent rural health clinics and provider based clinics over 50 or affiliated with a hospital over 50 beds or any new that were not established prior to 1/1, they're now capped at this $113 per visit. And this is the rates for 2022. Each year they're set to go up somewhat as well. But it's important to look at that cost on your cost report for your rural health clinic, because even though you have a cap, you still, if your costs aren't calculated on the cost report that high, you're going to get the lesser of the two. You're either going to get the cap or you're going to get less than that. So it's important to still look at your volume, to still look at your expenses, and to make sure that they're matched up appropriately. So there is a huge range in the provider-based clinic AIRs as well, inclusive rates as well, to barely $100 to well over $400 a visit. So if you were set with a really high cap, you really want to look at that to make sure you can stay as high as you can. Now, if you drop in 1 year and the next year goes up, you can go back up again. You're not going to be reestablished at a lower rate as of right now. But keep in mind that if the calculated AIR is less than the cap, you're going to receive the cap. You're going to receive less than the cap. So if you have a decrease in expenses, if you have an increase in your FTE for your providers, an increase in your visits, and this is where the cost report really matters, not necessarily now as well as in the future, because we don't know what the future is going to be for those rates. Looking at, again, the rural health clinics, it's important to make sure you're optimizing those costs, make sure you have accurate visits, your FTEs, and your costs are all extremely important. The cost report and the accuracy is what's going to give you your optimal reimbursement. So there's different areas within there. There's the cost for the rural health clinic. making sure that you have your providers, your support staff, your supplies, everything that's directly related to that rural health clinic. You're going to have to track your telehealth separately because it's not considered a rural health clinic service. But make sure you include all your costs, direct, step down, and stats if it's a provider based rural health clinic. When you get into the FTE, here's an area that it's really important to monitor and look at, making sure you keep your employed separately than your non employed. One full-time provider on the payroll doesn't equal one FTE for your rural health clinic cost report purposes. So for a rural health clinic provider, let's say a physician that is full-time, there's a 1.0 on the payroll side of it, but they take 4 weeks off a year between holidays and vacations. They're really a 0.92 at the high end instead of a 1.0. So if you have 48 weeks, they work out of 52 at 40 hours a week, they're really only going to be a 0.92 FTE, not a 1.0. And that's going to be really important down the line as more of these provider-based exemptions are starting to be, they'll start to be harder to utilize once the pandemic has ended. Right now, again, make sure you're also looking at the hours that those providers are available in the rural health clinic to see and treat patients, not their CME time, not their PTO time, not their non-productive, if you want to call it, times and meetings. And then make sure, this is a huge one, to make sure you're really documenting this one well. Looking at the visit sides of it again, don't look at the visits on your internal stats reports. A lot of facilities really like looking at the stats report and showing how productive their physicians are, how productive different service lines are. And that's important for internal stat purposes. But when you get to the cost report side of it, one appointment does not mean one visit. So you really want to look at the different CPT codes that are an equivalent. For example, a 99211 or a nurse visit is not considered a visit. And you really don't want to overstate your qualifying visits because that will decrease your rate at the end of the day. Track your vaccines as well for reimbursement. The one thing that's the flu and the pneumococcal, and then with COVID starting as well, and flu and pneumococcal for Medicare only, not Medicare HMO, and then also looking at your COVID-19. That you can also put Medicare HMO on the cost report for the vaccine cost of that as well. And that's another area that sometimes it gets missed on the cost reports. One area that we really see looking at a lot of rural health clinic cost reports is the bad debts. Bad debts are usually blank. There's usually nothing on it. So that's an area to look at and focus on your cost report as well. And look at, that needs to be any patient or deductible and copay that's not paid by Medicaid or by the patient. You still need to follow the same rules as you would for the hospital side. And again, that value is 65%. So the more money that you can collect up front from the patient and the less you send to the patient or send a bad debt, the better off you are as well. There's also the provider productivity exemption requirements. And if you don't meet these requirements right here, you're actually penalized. Right now, there's a fairly easy exemption you can get during COVID, but that exemption is actually eligible outside of COVID. You just have to prove it more as well. And we've been successful in retroactively getting approvals based on the community side providers, and again, telling that story. So don't let that go. If you don't meet the provider productivity rules, take a look at that one as well. And then again, all these opportunities listed on here are eligible for retroactive reimbursement. They're not just prospective as well, by looking at the cost report as well. Other services, pay close attention to services that are not included in your AIR. Look to make sure that you're getting the current reimbursement for them. Look at any of your commercial contracts, your commercial payers, and really look to see what happens there as well. The other area is you can also look at consolidating your rural health clinics. It isn't all or nothing, but then you can look to see if you are better off doing that way from your provider productivity and your rate as well. But you make sure you not model it to make sure it's a good approach as well. Again, it's not a one size fits all. Different areas have different choices. It's a different scenarios, different considerations. So don't, just because someone down the street or another counterpart of yours has done it, doesn't mean it's going to necessarily work for you. You still want to look at that. When we're looking at the rural health clinics for Medicaid, again, we have 14, or actually we have 19 different states represented on the call today. So it's going to be pretty hard to get into specifics, but a lot of times this is a missed opportunity as well for rural health clinics. Even though Medicaid is a federal program, it can be administered different in each state. So make sure you take a look at that, see what opportunities you're eligible for. And again, making sure that you have the right payment visits as well, because that's gonna make a difference on your reimbursement. Looking at other opportunities for rural health clinics as well, you want to make sure you establish reviews to ensure your levels of service are billed appropriately to non-government payers, have processes for collection, those for collecting for those private and commercially insured patients and self-pay patients. And even if the commercial payers are a small percentage of your volume, this could be where your profit is sometimes as well. Look at your different Medicare managed care contracts, your Medicaid fee for service, your Medicaid HMO, any of your commercials. And again, making sure that, because you can bill differently for your commercial insurances than you can for Medicare and Medicaid. The third rural health provider type is local community hospitals. I'm not gonna spend a lot of time on those, but there are 450 of them across the state in 47 states. And what they can do is they can receive a higher hospital-specific rate and a higher federal rate as well. They can also be eligible for 340B with an 8% dish adjustment, and they also receive a higher APC payment for outpatient services as well. So they have a unique space in the country as well for the rural side. The fourth rural health provider type out there that we mentioned earlier is the Medicare dependent hospitals. The primary benefit of those is again eligible for the payment based on hospital specific payment rates. Um, and everyone with that it was a low volume or Medicare dependent hospitals has side or relief because at one point in time, those two designations were going to be scheduled to sunset on September 30th with the federal budget. But there is right now a temporary extension until 12/16. So if you're in a rural facility that is a Medicare dependent hospital or a low volume hospital that you receive low volume add-on payments, make sure you get a hold of your Medicare contractor right away. Most of them are still requiring you to submit something within a very short period of time to be eligible to continue on with those benefits as well through the middle of December. And then when Congress comes back into session, they're hoping through the next budget package that it'll be extended longer. Rural referral areas are the fifth provider type. Again, there's only 460 of them across the country, so it's a little bit smaller group as well. Again, the biggest areas then again are the 340B and the dish adjustments as well. Looking at the rural health reimbursement for those PPS facilities, again, a lot of this is the same as what I already mentioned, but you really want to have a strategy to look to see what your current reimbursement is for all the different programs out there. There's rate setting implications, still has a relevance, your uncertainty of the future Medicare changes, and also monitoring for performance. Where's your volume sitting? Are you losing money on Medicare? The other thing that's really important with the Medicare cost report is it's going to affect your S10. Has become extremely important with your indigent volume. Your cost to charge ratios on there will impact that. Your Medicare bad debts are another area to keep in mind, and model any impacts that you change as well. So looking at other, for the Medicaid side, again, we have a variety of different states represented on the phone, but there's still going to be an impact on your supplemental payments from your state, your hospital specific taxes if you're in one of those states as well. And keep in mind to make sure with those supplemental payments that you're optimizing your share of them, that you monitor and reconcile your HMO clearings, that you look at your uncompensated care, make sure it's accurate, and that you watch your cost to charge ratios from your Medicare cost report because that'll get there as well. Other reimbursement opportunities out there as well. Look at your commercial contracts. Make sure you have accurate charging to those commercial payers as well. Grants and donations are another area that's really nice no matter what type of provider you are because the cost reimbursement side of it, you don't need to offset and do an A8 on grants and donations. So those are technically kind of quote unquote free money. A few other areas, again, don't miss out on the other reimbursement opportunities. If you're in a HIPSA, you can receive different add-on payments for that one as well. Some are auto HIPSA designations, some you'd have to apply for. There's 340B, which is a huge area to look at with your provider-based clinics, especially if you're using a contract pharmacy. With your managed care contracting, make sure your insurance companies know that they need your rural facilities there when you're looking at that geographic coverage. If you're close to a border state or another state, make sure you're looking at that out-of-state Medicaid patients on your cost report as well as your supplemental payments. And then there's always opportunities to look at rural cycle opportunities as well. On your health system side of it, what I see here is sometimes the rural areas have a different strategy needed than the urban areas. And sometimes that's not always recognized by different systems. In looking to make sure that all the relevant services and the costs are being applied appropriately to those rural facilities, making sure that the contracts are written differently, to make sure that you are categorizing that appropriately, making sure again with your Medicare cost report that you're getting all the costs down there, to get that additional reimbursement, especially if it's a critical access hospital. The rural health clinic side as well, especially if you're cost-based reimbursed with provider-based. And then review the charge master rate. So sometimes facilities will have an overarching charge master. And what I've seen in some smaller facilities is with the 20% outpatient payment that has to go to the patient, that has been detrimental to a few. So if there's some that because the charges were so high, that it actually produced an 18% cost to charge ratio, which meant that Medicare wasn't paying that critical access hospital for any of their services. 100% of that cost for those services was going to the patient. And that's something that you really want to take a look at to see if it needs to be different or not. Make sure that someone on your team really understands the rural health and the opportunities that exist, and that there are different issues and they require different strategy. Both are right, but they're just different between rural and urban. And what is good for an urban hospital is not necessarily beneficial for a rural hospital. Again, looking at those charge masters and making sure that you're not out of place for that. Claudine, I think we're ready to the second polling question, the last polling question, please. Thank you. So you should see it up in your team chat now. And but this is as regarding your COVID funds and just asking if you used all your funds to cover lost revenue, if you lose all your funds to cover COVID related expenses, if you used your funds to do COVID related expenses and revenue, if you had to return some of your funds, if you're unsure or if it's not applicable, if you don't work for a healthcare organization. Let's give it a couple quick, about 10 more seconds here. So this is one area that I'll just talk briefly as everyone's answering that there's a wide variety of different ways you can do that. And it looks like the majority are using for both lost revenue and COVID related expenses. And the one thing, if you're a cost-based facility, keep that in mind that you're not double dipping on that with the cost report as well. But um, and one of you returned the funds. That makes me sad, sorry. I that's, unfortunate if you had to return some of the funds, but the one thing that happened, when COVID started in April, for those that were in the healthcare industry at that time, second, third quarter 2020, the government sent, a lot of funds to all providers across the country, and specifically rural providers received their own special distribution pools as well. So for those of you that are still working through some of that as well, again, it's nice to see that majority of you were able to use your funds to cover lost revenue and COVID expenses. So I appreciate the feedback on that. Thank you. So for those of you that received the Medicare Advanced and Accelerated Interest-Free Loan back in April 2020, by now you probably, if you haven't paid it off, you would have received a demand letter unless you were late in getting your funds. If it hasn't been paid in full. The Paycheck Protection Program was another way that a lot of individuals, again, keep documentation on that. They didn't have a high level of audits on those, but that doesn't mean that's not going to change. With the rural health clinics, there was waivers of provider productivity limits, as I mentioned earlier, that could be requested directly from the MAC during the public health emergency. There were also specific federal funding programs. Most funds were automatically sent to the certified rural health clinics, but a few funds actually required the applications. And there are different reporting requirements for those rural health clinics. So don't forget, if you have rural health clinics, there's different reporting that you have to do with that than you do with the provider relief funds, and different uses of those funds as well. Those cannot be used for, if you receive rural health clinic specific reimbursement through the government for COVID related, it cannot be used for lost revenue. It has to be used for expenses. Just keep that in mind. And there is different reporting timeframes and different reporting portals for that. For the provider relief funds, again, the majority of the funds were automatically distributed based off your cost report, off worksheet G of your cost report. And again, a lot of those have to do, most of you would need a single audit done with that. You've probably finished your phase 1 and phase 2 if applicable. Phase 4 reporting is starting right after the first of the calendar year in January. And again, there's other governmental fundings available at different levels, whether it's a state, association, local. Sequestration also was suspended, but now it's back to the 2%. Be very careful not to overlap your funds, and this is where the documentation is key with that. Again, the government did a great job of sending as much funds out as possible to healthcare providers when the COVID pandemic started in March of 2020. Unfortunately, a lot of rural providers were sitting with more cash than they were sitting probably 6 months to a year ago. They were probably sitting with more cash than they were pre-COVID through a lot of different methods, whether it was the Medicare Advanced and Accelerated Payment, the PPP loan, on the provider relief funds. And the majority of them were very cautious to spend anything with no strings attached until the final guidance was issued. But now the various changing guidance, some of those have now been, strings have been reattached and changed again and everything else. But the hardest part is with the federal funding kind of masked the instability of a lot of those at-risk rural hospitals. They appear now more financially stable than they really are. So there, a lot of those are really starting to struggle a lot more right now. I hope you're not one of them, but if you are, unfortunately, you're not alone right now. But it just not was not good that way. Another thing, this is where it's really important, no matter if you do the cost report or if you work in a different area within the facility, but education and communication is important for staff to understand. If money's being spent, how is it going to impact your reimbursement if you are a cost-based reimbursed facility? Just to understand the implication. It doesn't mean you should or shouldn't do it if it doesn't go on there, but you just really need to understand how the reimbursement is tied to the cost report. Every decision is made is impacts reimbursement, and you really need to model those changes and consider more than just Medicare. Again, sometimes there's that turnover in the C-suite, through the boards, the managers and directors. The myth is sometimes as we're critical access hospitals, so we should always break even because we're reimbursed costs, when really that's not true. Again, you need to make up the difference the Medicare shortfall is to those non-Medicare patients. It does add another level of review complexity. So make sure you're looking at interim cost reports or modeling whatever you can. Again, no matter what type of provider you are, you still want to make sure that it's the right decision, and looking at it that way. And we're getting low on time, but we are almost done. Rural healthcare in the future. So there's a new rural healthcare provider type out there established, the rural emergency hospital. I'm sure everyone's heard of it by now. Again, it's a response to a loss of emergency services in rural areas due to hospital closures. It's going to be starting effective January 1st, 2023. They just came out with the final rules last Thursday on it, last week on it. I don't remember which day it was that they just came out with the final rules on that. There's a lot of different mechanisms out there. Again, you're going to want to look in, if you're looking at that as an opportunity to change your provider type, you really want to look to make sure, is that going to financially be beneficial for you, and what does it mean for your community? Because there could be two different impacts there. Cash, again, is important to keep your hands on as much as possible. The unthinkable can happen and the bottom can drop out, and it did over the last couple of years. So you just really want to get as much cash set aside as you can. Again, 80 rural hospitals have closed since 2010, so that's a significant amount. Again, oops, sorry, I went too far. You just want to make sure that you're not going to be one of those rural hospitals that's going to close in the future. So, and the other thing that's interesting too is the funding mechanism of it. So we got telemedicine, technology and infrastructure. The future, it's really hard to know how the funding is going to work, because healthcare is the largest industry that gets federal funding, and the U.S. healthcare spending is actually up almost 10% in the last couple of years to now $4.1 trillion. So it's almost 20% of the GDP. So that's going to be, and healthcare costs are growing faster than the GDP is. So we really need sustainability, but sometimes that makes us a target in the budget as well when we're Congress is looking at what they're going to do to pass a budget. With being such a high percentage of that GDP, it's going to be harder to keep all that funding there. So really want to look at that. And then just a quick summary again. I appreciate your time today, but looking to make sure you're just receiving the funds you're entitled to, nothing more, nothing less. Look for other opportunities or programs. Make sure you're able to reinvest in your facilities, providers, and staff to provide the best care and services your community needs. We can't be all things for all people, but do what you can do and do it best. And keep that passion to keep rural healthcare available to the 20% of Americans that call rural home. The cost report is not informational only. It does drive your reimbursement, whether you are a critical access hospital that's fully cost-based reimbursed or not. And make sure you model all your changes, administrative understanding, and also it may be small but seemingly minor changes can sometimes make a huge, big reimbursement impact, and the same in return. Think of a large change will help tremendously, but it could actually be a minimal change depending on the impact of it. Here's a list of resources that were there. There's lots of information here as well. Fact sheets are good. Sign up for listservs. And then if there's, I think, any questions that were addressed ahead of time, I'll reach out to you individually. And then if you have any other questions, throw them in the chat, please. That would be great. Thank you. There will also be a link to the survey if you can hang on just for that, or also be emailed out later. Again, thank you. If you work in a rural healthcare facility, thank you for your time and dedication for doing that. We really appreciate having you here today.
Karen, you did have one question that was posted in the chat. The question was, how does our charge affect what Medicare will pay? You said if our cost is high and they send 20% to patient, is 18% of? Think someone
So,
need,
yep. So in regards to that, the on the if you are a critical access hospital, your outpatient charges, 20% of the charge, excluding lab and mammography, gets billed to the secondary insurance or the patient. So it's all based off charges for the outpatient side. And then through the cost report, it looks at what your costs are, what your charges are. And then if your cost to charge ratio is less than that 20%, it's going to then bill 100% of it to the patient. That was an extreme scenario that I hope none of you have. Generally speaking, cost to charge ratios are probably more like between 45 and 55%. So at the end of the day, there's a certain percentage of that that's going to get billed to the patient based off charges. So some areas it actually looks at the cost side of it or the reimbursement side or the Medicare approved side. But Medicare outpatient for critical access hospitals bills 20% to the patient or their secondary insurance. Hopefully the majority of your patients have secondary insurance or their supplemental insurance of some sort. But I'm not sure if that clears it up anymore. If not, feel free to reach out to me and I can try to explain it better.
great, thank you. All right, and this concludes today's webinar. Please do take a few minutes to complete the survey. I provided the link in the chat. A copy of the survey link will also be emailed to you, as well as a copy of the recording from today and today's slides within the next few days. In the meantime, as Karen mentioned, if you have any questions, please reach out to her. Her information has been provided, and hope all of you enjoy the rest of your day.